With regards to my lecture, these are the differences from the 10th and the 11th editions. Okay, there's a new path. They have new pathways for cellular response to stress and injury. That's the protein folding. Okay. Chapter 3, no change. Chapter 4, updated coagulation pathways, septic and sepsis. Okay. And of course, there's always changes in molecular diagnosis for new patients. Okay. If you want to know the conditions. Well, not very important. We'll begin with our chapter today, with chapter 2, cell injury, cell death, and adaptation. Alright? So, when we talk about pathology, what's your understanding of pathology? What is pathology? Okay. If you go from the literal term, patho means suffering. So it is the study of suffering. But in a modern sense, it's diseases. Because there are many ways people can suffer. But in this case, diseases. And so when we talk about diseases, there are always 4 aspects of the disease. Number 1, the etiology. Be it a genetic cause like Down syndrome, trisomy 21, be it an environmental cause such as smoking, or more commonly, multifactorial like diabetes and high blood pressure. They're all will combine in genetic and environmental. Okay? Pathogenesis is the mechanism of the disease. Okay? What are the molecular, biochemical changes and alterations that this disease produces? The morphological change, back in the past, we talked about morphological change as in what you see in the microscope. But it's a little bit more broader now because there are also proteins that are produced by tumors and there's molecular changes as well that are important. Okay? So the molecular alterations are also important for the disease. And of course, lastly, the consequences of the molecular or the morphological, molecular, and pathogenesis would give you the clinical manifestations. Okay? So those are the 4 aspects of disease. Alright? So let's start here with this very famous drawing. A normal resting cell that's just doing its thing in a normal controlled environment is said to be at a state of homeostasis. Okay? Meaning nothing's bothering it and it's working at its normal average job. Okay? Whenever there is stress or injury, one of 2 things can happen. Either the cell itself will have to adapt and reach a new balance of homeostasis, and if it can't do that adaptation, the cell will become injured. Okay? So looking at this, we will go to adaptations and cellular response to stress. Okay. So when we have stress, be it maybe reduced oxygen or reduced blood flow, the cell will have to adapt. So what is an adaptation? So an adaptation is a reversible functional and structural change. Meaning, if the stress is removed, the cell can go back to what it originally was. Okay? That means it's reversible. It's changes. Okay? And these stresses can be physiological, maybe you're working out, or it can be pathological, you have a disease. Okay? But either way, the adaptation allows the cell to maintain a new level of homeostasis with the adaptations. Okay? And what are the adaptive responses? These are the examples. Okay? And you're going to encounter this quite frequently. Okay? Hypertrophy, hyperplasia, atrophy, and metaplasia. Okay? You have to know all of them. Okay? So hypertrophy is an increase in the size of cells. Okay? And I'll be showing you examples later. Hyperplasia is an increase in number of cells. Atrophy is a decrease in the size of cells and its activity. And then metaplasia is the replacement of one cell type to another cell type. Actually, you've probably seen some of these changes already. Let's talk about what we have in the lab. Okay? We have lab on, I believe, Thursday. Yeah, Thursday and Friday, one of those 2 days. So these are the slides that we're going to be showing in the lab. We actually do have a brand new set of pathology slides last year. Okay, the slides are pretty decent. Okay, And we also have old slides, which are actually not acceptable, but if you use your imagination, I'm sure it will be acceptable. Okay, so let's talk about the first one we have. Hypertrophy. Okay, so here is a cross-section of a muscle tissue. Now, I hope you're good in your histology. What type of muscle am I showing you? Smooth, skeletal, or cardiac? Yeah, it's skeletal. The only thing is it's a cross-section, not a longitudinal section, so you're not seeing the striations. But you can tell it's skeletal muscle, okay? Nuclei push to the periphery, okay? And it's multinucleated, okay? So this is a skeletal muscle. So what we have here on the left, we have normal skeletal muscle. On the right, this is actually the same magnification. It looks like we zoomed in, right? It's not actually zoomed in. What happens is the muscle cell has produced more fibers and has grown enlarged. So what happens when those people who are bodybuilding? Do they have more muscle cells? No. Muscle cells have very limited capacity for mitosis, so they can't do hyperplasia. Instead, what they do is they produce more proteins for more contractile filaments to produce greater strength. And that is an increase in size of cell, hypertrophy. Okay? It's the same magnification, guys. It's the same magnification. So I didn't zoom in on the right. It's the same. Okay? So that is hypertrophy, increase in size of cell. Let's look at this one. What do we have in this tissue? Or what organ do you think this is? It is actually a uterus. We have two uterus. Okay? The big one on the left, it's very large. That's from a mother or a woman that was pregnant. Okay, that's a woman that was pregnant. Whereas the one on the little smaller uterus is actually the normal size, about a little bit bigger than your fist. Okay? So during pregnancy, what happens to muscles? Again, also going to increase in size. Although smooth muscle actually can also do hyperplasia as well. Okay? They can actually also do hyperplasia. It's skeletal and cardiac muscle that cannot do it. Okay? So we look at this here, the normal smooth muscle fibers, and we compare it with this enlarged muscle fibers there. That's hypertrophy. Okay, next we go on to hyperplasia. Okay, this is an increase in number of cells. Okay, so the classic example we have here is identify organ. It's breast. Non-lactating breast. That's actually correct. So you do remember your histology. What we see are lactiferous ducts and glands surrounded by a fibromuscular stroma. Okay? So this is an inactive breast. So what happens during pregnancy to the breast? There is hyperplasia, meaning an increase in number of cells. So what will you see more of? You'll see what type of cells? Fat cells? Fibroblasts? You'd expect to see more glands and ducts. So here it is. And you see the acini are much larger. There's more glands, and we see ducts, some of which are already filled with breast milk. The fibromuscular stroma that we saw earlier is very scanty, very pushed to the side and smaller. That's why during pregnancy there is enlargement of the breast due to hyperplasia. Okay. Next adaptive changes. So that's a physiological example of hyperplasia. But we also have pathological changes. Okay. So here's another picture. I hope you know your histo. Identify the stage of the endometrial cycle shown on the right. You know what stage is that? Secretory, you would have tortuous, and then you would have the supra or subnuclear vacuoles and secretions. But these are not yet tortuous. They're proliferative. So this is the proliferative phase. That's why I'm always telling you, you really have to be strong in histo. Okay? So this is the normal, on the right is the normal. The glands are straight, more or less straight, proliferative. But what happened here on the left side? Oh, it's a little blurry. Well, it's not blurry on my screen. The glands are they're not actually the secretory, because the secretory is the sawtooth pattern, remember? They're more disorganized, so to say. They're weird in shape. Some of them are even cystically dilated, okay? That's endometrial hyperplasia. Okay? Endometrial hyperplasia. The glands have been proliferating, and it's usually due to an imbalance of hormones. Okay? You'll learn more about that in a moment. What's also more important, though, is to identify whether there's atypia or not. Okay, but you'll learn about atypia when we talk about neoplasia. Okay, so we always call it endometrial hyperplasia with or without atypia. If it's with atypia, that's a little bit more troublesome, okay, because it can become malignant. Okay. All right. Here's another condition. Do you know what organ we have here? Prostate, because it's labeled at the bottom. That's why. Okay. So, have you ever noticed sometimes in like the very elderly people, they have trouble urinating? It comes out in what we call like dribbling. Or sometimes they wake up in the middle of the night and then they urinate. Or sometimes they urinate, 5 minutes later, urinate again. It's common because of this condition, BPH. Okay? Benign prostatic hyperplasia. Although some people call it hypertrophy. Technically it's hyperplasia. But the clinicians are not pathologists, so they interchange things. It's fine. So what happens? If you think about it, the glands become bigger. Okay? The normal glands are usually the undulating glands, but now they become dilated. And the whole gland enlarges. And when it enlarges, it compresses the prostatic urethra. That's why it's difficult for the person to fully empty the urinary bladder. Hence, that's why, if you know the physiology, you can also explain the clinical manifestations. Okay? So what I want to show you. Please tell me if I'm going over the time limit, because this is a very long slide. Next, metaplasia. Actually, there are different types of metaplasia. Okay? So, metaplasia is where you have a cell that's then replaced by another cell. Most of the time, it's one epithelia to another epithelia. But sometimes it can be epithelia to connective tissue or something else. So I'll give you one example here. We have squamous metaplasia. So in here, we can see usually, the best example I can probably give you is in the trachea of a smoker. Okay? So what's the normal lining epithelium of a trachea? It is pseudostratified, ciliated, columnar with goblet cells. Okay, glad you know that. What happens though in a smoker is that epithelium is not meant to handle toxic substances and pollutants. But what is? It's actually squamous. So the cells will be replaced by stratified squamous epithelium, okay, which can better withstand the toxins and pollutants from the cigarettes. But that comes at a price. Okay, that comes at a price. It's a double-edged sword. Okay? Because yes, it could withstand toxic and pollutants, but that squamous epithelium is at a greater risk for becoming cancer. It's fertile ground for cancer. And usually the most common type of cancer in smokers is squamous cell carcinoma. Squamous cell. Okay. So let's take a look at that. So here we have a very nice picture and diagram. So on the top, you can see the diagram of the epithelium, although it's simple columnar there, but it's supposed to be pseudostratified, huh? But understand it's just a diagram. So on the left, we see the pseudostratified columnar at the bottom picture with the cilia and the goblet cells, but notice on the right, it becomes stratified squamous. That's metaplasia. Squamous metaplasia to be specific. You can also see squamous metaplasia in the cervix. Okay. Here, this is a bronchus, although you don't see the hyaline cartilage, it's in a different area, but it's a bronchus. Notice the epithelial lining is still stratified squamous when it should be respiratory, okay? Or at least columnar. Okay. All right. So what happens if adaptation fails or if the stress is too much? There's injury, okay? There is cell injury. And this injury can either be reversible injury if the stress is mild and transient, or if the stress is too much, it can be severe and eventually cause irreversible injury, which leads to cell death. Okay? So let's talk about cell injury. Okay? So if limits of adaptive responses are exceeded, okay, we have injury. So what are the causes of injury? Well, usually the most common are listed here. Oxygen deprivation, that's hypoxia. Okay? Hypoxia. Hypoxia can be caused by many different causes, such as ischemia. And ischemia is reduced blood flow. Okay? But maybe you could have hypoxia because you're anemic, not enough red blood cells to carry it as well. So know the difference between hypoxia and ischemia. Okay? Ischemia, reduced blood flow. Hypoxia, decreased oxygen. All right, you could have physical agents, chemical, infectious, blah, blah, blah. You can just read the list there. All right, so let's go to reversible injury. What do you see? Okay, histologically wise, you see swelling of the cell. Okay, what actually happens is the cell cannot maintain its proton pumps, so water will enter the cell. Thus, it becomes swollen, bigger, and large. Okay, and in some cells that actually have a lot of lipid metabolism, like the liver, you can see fatty change. Okay? So you would see the accumulation of lipid droplets and lipid globules within the cell. Okay? Those are all reversible. So if you restore the oxygen, these will eventually go away. Hence, reversible changes. So what we have in the lab, we have fatty change of the liver. Okay? So, the accumulation of triglycerides and lipid droplets. So, do you remember the histology of your liver and its appearance? So, here's the normal liver. Okay, nice, round, smooth. And we have this. Do you remember these structures? Let's look at high power. What am I showing you here? Oh, very good. And what are the components of your portal triad? The large one with the big lumen is the vein. The one with the cuboidal epithelium is your cuboidal epithelium. Bile-ductular. Because blood vessels are simple squamous, so the artery is the one with the thicker muscle. Okay? So that's your portal triad, the normal one. And then of course the cells here are your hepatocytes, okay, which are forming the hepatic plates. In between are your sinusoids. That's your normal. Okay? But let's look grossly at something that has fatty liver disease. Actually, there are many causes for fatty liver disease. Okay? That's a general response to many things. And in fact, we actually classify it as to alcoholic fatty liver disease versus non-alcoholic fatty liver disease, NASH. Okay? So there's a lot of things that can cause fatty liver disease. Obesity, injury, okay, etc., etc. So you'll notice that it becomes more yellow because of the accumulation of lipids within the cell. So what does it look like microscopically? Here we have, you see how it looks like it has these little bubbles? Okay. Those are actually the lipid droplets, the little bubbles. We can actually classify the type of steatosis or the type of fatty change as microvesicular, small, or it could be macro, the bigger vesicles. You don't need to know that yet. Maybe when we go to the liver. But just for now, it will suffice that you can identify this as fatty change, okay, which is a reversible type of injury. Here's another one. Okay, they're all fats. This is a macrovesicular because the droplets are larger. Okay, that's macrovesicular. Okay. So those were the reversible injuries. Cellular swelling, fatty change. Let's go to what happens in irreversible injury and ultimately cell death. So there are two major patterns of cell death, necrosis and apoptosis. Although nowadays there's some overlap between the two. So let's talk about necrosis. So necrosis is death of tissue, and it's a consequence of severe and or prolonged injury. Okay? The cellular proteins are degraded or denatured, leakage of enzymes. Okay. Actually, you have this diagram here in your 11th edition. Okay? So this kind of will summarize everything. Okay? What is important to know is its difference from apoptosis. Okay? So when you have necrosis, the cell will die. Okay? And when it dies, it leaks its contents into the extracellular matrix. When it leaks its contents, this elicits a strong inflammatory response. So it's expected that you'll see a lot of white blood cells surrounding necrotic areas. As opposed to apoptosis, in apoptosis, the cell will actually shrink and fragment into small bite-sized pieces. And these bite-sized pieces do not elicit an immune response. Instead, they are taken up by resident macrophages. So we see less inflammation in apoptosis. Okay? So this is the one that's also very important because it comes out in exams. The patterns of tissue necrosis. This will most definitely come out in your exams. Your board exams, your diplomats. Okay? So when large number of cells dies, we said that the tissue is necrotic. Okay? And they have several distinct patterns, and some of these patterns are associated with certain diseases. Okay? So we'll show you some of the slides in the lab. The first one, coagulative necrosis. Okay? So it's like if you ever have an egg and you fry it in the frying pan, what happens to the egg white? It becomes solid. That's coagulation. Okay? So in this type of necrosis, the architecture of the cells is maintained. Okay? So what you see are kind of like ghosts of what the cells used to be. You can still identify what tissue it used to be. Okay? And because it's solid, it's going to have a firm texture. Okay? So what you usually see, the cells are dead. They're more brighter red than they should be. Here's what we have here. So we have a kidney that underwent an infarction. Okay? So we see this wedge-shaped area that died. And if we look at the histology, it's very nice here. Which do you think is the viable tissue and which do you think is the necrotic tissue? The upper right or the lower left? Which one is viable? Yeah, lower left, because you still see that they have the nucleus. You can still see the glom. Okay? You can see the convoluted tubules, but if you look to the upper right-hand corner, you'll notice that the cells are very pink and they don't have nucleus. Okay? The cells there are dead, and you'll even see a lot of inflammatory cells in between that are going to eventually eat up the dead cells. So that's coagulative necrosis. The architecture is still maintained. Okay? Do you know what organ this is that underwent coagulative necrosis? You are correct. It is cardiac muscles. You still see the branching pattern, although the nucleus are kind of gone and the cells are more pink and the striations are not quite as vibrant as they used to be. This heart underwent myocardial infarction or a heart attack, so to say. So the cells here died, but they still maintain its architecture, so it's coagulative necrosis. Here's what it looked like grossly. So this white area represents the infarcted area. Okay? And the red is the viable area. You'll also notice that the muscle wall is very thick. It's very thick than normal. So you'll learn about that. It's cardiomegaly, enlargement of the heart. Alright. Next, we have fat necrosis. Not to be confused with fatty change, huh? They're different things. Fat necrosis and fatty change are different. One is reversible, one is already necrosis. So the best example that you can see in this one is in the condition acute pancreatitis. Okay? So what does the pancreas do? So the pancreas has a lot of digestive enzymes. Okay? So in acute pancreatitis, most of these enzymes, when they're stored in the pancreas, they're inactive. Okay? So to protect the pancreas from eating itself. But in the case of acute pancreatitis, The two most common cause of acute pancreatitis, chronic alcohol use and gallstones. Okay? What happens is they would actually activate the enzymes within the pancreas, so that literally the pancreas is going to be digesting itself. And the patient will die because there's usually a lot of blood loss in this one. There's a lot of blood going to the pancreas. Okay? That's the one where you see someone who's chronically drinking and then they die in the next morning for some unknown reason. Usually it's chronic pancreatitis. Okay? So, what do you see grossly? Grossly, if you look at the pancreas or in areas of fatty necrosis, you'll see that there are these little white chalky deposits. Okay? That's called fat saponification. It literally turned to soap, because soap is actually made of fats. Okay? So you have these little solid, chunky, white, chalky deposits. That's fat saponification. Okay? And then microscopically, what you see are dead fat cells, inflammation, okay? Calcium deposits if possible. So it looks like this. This came out on my implement exam. You see those white spots here? Yeah. That's the areas of fat necrosis. The white spots here. You can see a lot white spots. That's the areas where the fat became soap. Okay. And then histologically, what do you see? You see dead fat cells here, which is the right area. This used to be unilocular adipose tissue. Okay. It's kind of all dead. And as well as we see a few viable glands, but they're also dying in this area here, okay, in the middle. So we see the dead fat cells on the right, a few viable cells here, and necrotic areas. Okay, so that is fat necrosis. Right. Here's another one. This one is more on the fat itself. Notice the fat has no nuclei. Okay. There's no nuclei. That's usually pushed to the side. So you kind of have to look carefully, and it's a little bit more pink. Okay. Here's another one that has a lot of inflammation. Okay, we see inflammation. Next one. This one always comes out. Caseous necrosis. Caseous means cheese-like. Okay, cheese-like. Because when you look at it, it's supposed to look like crumbly cheese, maybe like blue cheese or feta cheese. If you look at it. This always comes out here in the Philippines because this is very associated with what condition? Tuberculosis. Okay, they always ask that question. Tuberculosis. So grossly, what actually happens here is the body can't exactly kill the mycobacterium. So instead, they try to quarantine it. So that's the body's attempt to quarantine the tuberculosis with caseous necrosis. Okay? So cheese-like. Here's another one. So it does kind of look like a little cheese. And here's actual cheese as a comparison. See, right? Doesn't it look like cheese? But don't eat it. Okay. Feta cheese or blue cheese, maybe, probably blue cheese. All right, how about the microscopic appearance? Now, microscopically, they form something called a granuloma. Okay. Actually, granulomas can be seen in also non-caseating inflammation. So a granuloma is an area that's being walled off by epithelioid histiocytes. Okay. That's a complex name. It's just macrophages that have an epithelioid shape. They look like epithelial cells, but they're not. Okay. So they're these macrophages that are forming a wall. And in caseous necrosis, the very center of the granuloma would be caseous, meaning cheese-like, meaning you see pink amorphous material. That's the caseous debris. And sometimes you can see a it's not actually pathognomonic, but it was originally described in tuberculosis. You see these giant cells. Okay. So let's take a look at what a granuloma looks like. So here's the diagram. The outer layer are the epithelioid cells. Okay. They kind of look like epithelium, but they're not epithelium. Okay. They're macrophages. In the center, you see this pink stuff. That's the caseous part, if it's a caseating granuloma. But not all granulomas are caseating. Okay. So you see this pink necrotic debris. That's the caseous part. Sometimes you see these very unique, large, multinucleated giant cells, which are called Langerhans giant cells. Not to be confused with Langerhans, because Langerhans is found in the skin, if you remember that. Okay. So these are Langerhans giant cells. What the Langerhans giant cells are is they're actually macrophages that combine to form a super duper macrophage, so to say. And so it has several nuclei that are usually arranged in a horseshoe pattern. Okay. I'll show you pictures of that. That's the Langerhans giant cell. And here's the diagram, or the actual slide. You see the pink amorphous center? That's the necrotic area. And these are the epithelioid cells surrounding it. Okay. For the giant cells, they're here. They're highlighted. So we see the pink dead caseous area. So this is a caseous one. And then the giant cells are here. I think I have a better one in high power. Here. At the bottom, you see the kind of like horseshoe shape? That's it. Okay. Although they are not pathognomonic for tuberculosis, you can actually see them in other illnesses, fungal infections as well, or even foreign bodies in granulomas. Langerhans giants. Right? And here are the several types of giant cells you can encounter, but the one that's associated with caseous necrosis is the Langerhans. Okay. But you can have sometimes foreign body giant cells. Okay. The nuclei are arranged in an irregular pattern here. Then you have totem giant cells, which you don't need to know. They're found in certain disorders, xanthogranulomas, to know that. And then we also have tumor cells that can also sometimes appear as giant cells. But you'll notice that the nuclei are not round and smooth. They're ugly and darker usually than normal. So those are the various types of giant cells you can see. So here's another one, Langerhans there. How about on the right? What type of giant cell do we have on the right and on the left? On the right we have the nuclei arranged in a circular pattern surrounded by lipid droplets. That's totem giant cell. And then the other one on the left with irregularly placed nuclei, foreign body. Foreign body. How about this one? What do you think this giant cell is? It's cancer. It's cancer. Nuclei, look at the shape of them. Some are like clover leaf. Weird. Very weird. That's bad. Okay. So those were the giant cells. So we could also have non-caseating granulomas. Okay. They don't have that pink central area. Okay. But tuberculosis is caseating. Right. Apoptosis, okay, also known as programmed cell death. Okay, programmed cell death. A type of cell death that initiates the suicide program. So what happens? The cell will break into smaller pieces and fragment and will be eaten up by regular resident macrophages. Okay? So these are the morphological features. Instead of swelling, you get shrinkage of the cell. Okay? Shrinkage of the cell because it's fragmenting into smaller pieces. Okay? Right. And lastly, you have the table showing you the difference between necrosis and apoptosis. Alright. And here it is. Then for the last part of this chapter, we have calcifications. There are two types of calcifications. Okay? We have dystrophic and metastatic. Both of these types of calcifications occur in different settings and conditions. Okay? So let's take a look at this one. So what is calcification? It's the deposition of calcium substances, usually calcium salts, okay, in tissues. Alright? So I don't know if we still have this in the lab anymore. We'll talk about first dystrophic calcification. This is seen in areas of necrosis. Okay? And the serum calcium levels are actually normal. Okay? So your serum calciums are normal, and you see this in areas of necrosis. So the best examples that we have are in atherosclerosis. Okay? When your blood vessels get hard, they first will fill up with fat, and then sometimes that fat will calcify. That's dystrophic calcification. Okay? You can also see them in those with damaged heart valves, specifically bicuspid aorta. Okay? Right, so let's take a look at them. So here is what do you have? Yeah, the aorta. So you see those chunky white deposits? That's calcification material. Okay. That's dystrophic calcification. Here's a normal aorta. Okay, it doesn't have that white stuff. Okay. So when you have this calcification, it makes it difficult for the aorta to close properly and function properly. So it can cause regurgitation, murmurs, etc. Okay. Histologically, what do calcium look like? They look like basophilic amorphous granular or sometimes clumped substances. Okay. Another type of dystrophic classification you can see is in some conditions are called Samoma bodies. Okay. Samoma bodies are concentric calcification, so they look like little layers of calcification. So I'll show you that. This is a normal blood vessel. Okay. All right. You already know the layers. Media adventitia. This one is with atherosclerosis. So we have a buildup of lipids in the tunica intima. You see the lipids. And sometimes in long-standing cases, the lipids will calcify. That's the black that you see here. Those are actually really hard. They're hard. That's what happens when you do not maintain your weight and blood pressure and exercise. This is the calcification. So when they put a stent, what do they have to do? Put a tube, balloon, they kind of push it to the side to force a wider lumen. Okay? And that's calcification. That's a long-standing case. That's pretty bad because if you look at the size of the lumen, the lumen is greatly reduced. Blood flow is going to be very troublesome going there. More so if this is a coronary blood vessel. Alright. Here's another type of calcification. This one is seen in a breast. So sometimes the tumor cells will die and then they become calcified. So that's another type of calcification. Dystrophic always occurs in areas of injury. Okay? This is the Samoma body. Although this is an excessive amount of Samoma bodies, because this is a pseumomatous meningioma. You don't need to know that. So you see these little round thingies? Although there's a lot. Those are the Samoma bodies. They're calcifications, but they're concentric. Sometimes they're associated with certain diagnoses. Like in this case, pseumomatous meningioma. You can also see Samoma bodies. Very helpful if you can see them in papillary thyroid cancers. Okay? They are never seen in other thyroid conditions. If you see Samoma bodies in an FNAP, be very suspicious of a nearby, probably missed papillary thyroid cancer. You can also see them as well in certain ovarian cancers as well. Although they're very hard to find from experience. The best one to really find it is the pseumomatous meningioma, which is actually rare. I've only gotten a few cases in my residency. Here is the papillary thyroid cancer. Okay, you probably won't understand it yet, but the Samoma body is there in the center. They're not quite that numerous as in Pseumomatous. Very good hint if you're thinking cancer. You see that. Right. Here's more. Those little black areas. This is another papillary thyroid cancer. And papillary thyroid cancer is the most common type of thyroid cancer. We are not at the end. It's not yet the end. We still have 2 more chapters to go. Okay. Still have energy? Let's move on to inflammation. Okay, how much time do I have? What time are we here? Till 3? Okay, so I still have time. Okay. Next, let's talk about inflammation. So, in the past, people thought inflammation is bad. Well, it's good to a point actually, because the whole point of inflammation is to bring about your inflammatory cells and mediators that can fight whatever is causing injury or damage. Okay? So, very classic, we always teach this. The cardinal signs of inflammation. You must know the Latin and the English. Okay? So, rubor is redness. Okay? Tumor is swelling, but now in the modern days, tumor is usually associated with cancer, but this is the Latin terminology, so it's swelling, tumor. Calor is heat, calories. Okay? Dolor is pain. Okay? And the last one is functio laeshea, loss of function. Okay? So these are the cardinal signs of inflammation. So what causes the redness? It's actually increased blood flow. What causes the swelling? It's actually extravasation of blood into the extracellular matrix. Calor, there's increased metabolic activity there. Okay? Pain, usually associated with swelling as well. Okay? And loss of function, if there's structural damage, loss of function. Alright, so those are the cardinal manifestations. We'll go to the next one. Causes of inflammation. There are lots of causes of inflammation. You could have infections, you could have necrosis, foreign bodies. It could even be your own immune system that's overreacting in autoimmune disorders. Okay? So the sequential steps in inflammation. So what happens first? There has to be a recognition to recognize that there is a foreign substance or an agent causing injury. Next, you have to recruit the appropriate cells. Then they have to remove it, usually by phagocytosis. Then finally, regulation. You have to cut off the immune response before it gets too much. And then finally, repair what has been damaged. So that's the order. Okay? So, recognition. So how do the body recognize various agents? Okay? There are a lot of mechanisms. You can have cellular receptors for microbes, sensors of damage, okay? Circulating proteins like your complement system, which acts as chemotraxins. Okay? I'm tired already. Recruitment. So you know that your white blood cells, they're located in the bloodstream. So how does a neutrophil that's in your bloodstream exit and go to where it's needed? So this is actually how it's done. Recruitment. So the first one we'll talk about is acute inflammation. Okay. So acute inflammation is usually the initial response. It's faster, short duration. The predominant cell is neutrophils. Okay. So the three major components: dilation, increased permeability, and immigration of leukocytes. So let's skip that. Okay. So vasodilation is done by several mediators, the most common of which are histamines. That's why in allergic reactions they turn red due to vasodilation. Your treatment is antihistamines. Okay. All right. So important thing here, increased permeability of post-capillary venules. So that's usually where the capillaries will dilate, and this is actually the site where your white blood cells will escape the circulatory system and enter into the extracellular system. It's the post-capillary venules. Okay? And this increased permeability is the hallmark of acute inflammation. So this is what I want to show you, this diagram. How the white blood cells will exit the bloodstream and then enter into the extracellular area. So in order, you have to know first the location of the white blood cells. Most of the time, your neutrophils are located in the center of the blood vessel. Okay? In a normal laminar flow blood vessel, your white blood cells are found in the center. So the first step is going to be called migration. Okay? So this migration is usually due to the capillaries in widening, doing vasodilation. So that slows down the blood. When the blood slows, the white blood cell will migrate from the center of the lumen towards the wall, or towards the endothelium of the blood vessel. That's migration. That's the first step. Next step is going to be rolling. Okay? So these neutrophils, they actually have various receptors which will actually attach. Where have it? It's not there. They actually have receptors that would attach to other receptors. They have receptors that will attach to the endothelium. And at first, it's only transient. So what happens, it's like if you take a tennis ball and you roll it